We are demonstrating antegrade nailing of femur shaft fractures. There are two possible entry sites, the standard piriformis fossa and the newer trochanteric entry fossa. It's important to have a nail designed specifically for the entry site chosen. We are illustrating here the piriformis fossa on the medial side of the greater trochanter, and here is the trochanteric entry site more laterally. Both are in line with the shaft of the femur on the lateral projection. With this system, there is a guide available so that if the first pin is not in perfect position, a second pin can be placed. It's better to use one of the holes that's not in the middle of the guide to maximize the potential for repositioning the second pin. We're illustrating guide pin placement in the trochanteric fossa with the sleeve that both protects the soft tissue and helps keep the guide pin lateral. Once the pin is positioned well on the AP and lateral projection, over-reaming of the proximal 10 centimeters of the femur is done with a reamer through a sleeve. Then a ball tip guide is introduced. This will eventually be passed across the fracture site. There is a pistol grip for control of the ball tip guide. This may be passed directly across the fracture with manipulation of the distal fragment. There is an internal manipulator available which will both move the proximal fragment into a reduced position, and it's curved at the tip so that the ball tip guide can be advanced medially, laterally, anteriorly, or posteriorly as necessary to hit the medullary canal of the distal fragment. This manipulator is passed over the ball tip guide down to the fracture site to manipulate the proximal fragment into a reduced position and to assist the passage of the ball tip guide into the distal fragment. This is typically done under fluoroscopic control. The ball tip guide can be advanced manually or with gentle taps with a mallet on the pistol grip. Once the ball tip guide is passed across the fracture and down to the physeal scar, the internal manipulator is removed. Length is measured using a special device. It's important to make sure that the device goes all the way down to the bone, that the fracture is well reduced, especially avoiding distraction or shortening of a comminuted fracture, and that the ball tip guide distally is seated at the physeal scar in the middle of the patella. You can see that it would be easy to put the guide inside the medullary canal and measure a nail that was too short. Progressive reaming is then done, starting with an in-cutting reamer. The other reamers are blunt-tipped. This 9 millimeter in-cutting will advance down the medullary canal through a channel sleeve. This minimizes the medullary debris into the abductor musculature, as well as direct injury to the abductor musculature. The reamer is passed at full speed, slowly advancing, not allowing the reamer to pull itself down the medullary canal. An obturator is available to maintain position of the medullary guide while the reamer is extracted. The next reamer is blunt tip. We typically advance 1 millimeter until cortical chatter is encountered, and then by 1/2 millimeter increments. Typical nail size for the femur is 11.5 or 12 millimeter diameter. The reamer is advanced in a controlled manner to avoid the reamer getting stuck. If the reamer does get stuck, a ball tip guide can be used to extract it. This illustrates the piriformis entry nail and the trochanteric entry nail. We're going to illustrate the piriformis entry nail because that is the entry site that we chose when we started this case. There's a nail-mounted guide that can be used for reconstruction mode proximal lock, where the screws go up into the femoral neck and head, as illustrated here. If recon mode is chosen, it's extremely important to get rotation correct. Otherwise, the proximal locking screws will penetrate out through the femoral neck in malposition. Standard greater troch to lesser troch proximal lock is also available through this guide. In this situation, rotation is less critical because penetration out the cortex will not cause any particular clinical problems. The nail is inserted with a series of gentle blows, never hitting on the guide but only on the advancing plate of the nail. Rotation of the nail is confirmed as it's inserted. There's a tendency for the nail to internally rotate. Rotation of the fracture reduction must also be confirmed radiographically and clinically. Once the nail is passed across the fracture site approximately 10 centimeters, the ball tip guide can be removed. This prevents incarceration of the ball tip guide or advancement through the distal femur into the knee joint. The pistol grip and a slotted mallet are used to extract the ball tip guide. Proximal locking is performed with a sleeve system once the nail is confirmed to be seated at the level of the cortex. This is drilled through the nail from the greater trochanter to the lesser trochanter, as illustrated here. Length is measured directly from the sleeve and the etchings on the drill bit. The inner sleeve is removed and the captured screw is inserted. This screw achieves bicortical purchase. This locks the bone around the nail proximally. This prevents malrotation of the proximal fragment. And in a statically locked mode will provide length stability. The capture device is removed, typically by hand. If it's been tightened too much, a T-wrench is available to remove the connection. The screwdriver is then removed in the sleeve system. Alternatively, reconstruction mode locking can be done with two sleeves going from the lateral cortex into the femoral neck and head. It is very important for the nail to be inserted just to the level of the cortex to ensure good positioning of these proximal locking screws. A guide pin is placed through the distal hole of the guide and the nail and then left in place. A drill bit is then passed through the more proximal hole, and under fluoroscopic control, length is determined, stopping approximately 1 centimeter from the articular surface. Direct reading of the length off the silver inner sleeve is performed. The silver sleeve is removed and the proximal locking screw is inserted. As previously mentioned, it's important to get a lateral radiograph to demonstrate that the first guide pin is in on both the AP and lateral. After the more proximal screw is inserted, the guide pin is removed from the more distal hole and the drill bit inserted, and then the screw inserted. Removal of the nail is done by a screwdriver to disengage the connecting bolt between the proximal guide and the nail itself. This illustrates correct position of the nail seated at the level of the cortex. Distal locking is typically done with radiolucent drill through a lateral to medial approach. Typically the C-arm is parallel to the floor if the patient's in the supine position. It's perpendicular to the floor if the patient is in the lateral position. Medial cortex is drilled and depth gauge is measured, either freehand, and then the screw is inserted. As you can see here, the thread diameter is greater at the base of the screw. It's important to seat it fully so the head of the screw comes in contact with the lateral cortex. 1 or 2 distal locking screws can be inserted. This illustrates the recon mode proximal lock and a single screw distally, both with a nail inside and one outside the Sawbone's model. The more distal hole is available for dynamic lock if some settling is thought to be desirable. In this case, the screw is placed most distally in the slotted hole. This illustrates the standard greater troche to lesser troche proximal lock technique.